Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Nirvi Shah. Ma'am is MBBS DNB, MRCOG, elective in gynae oncosurgery, fellowship in IVF, consultant at Aviva Fertility Clinic, Mumbai. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is USG interpretation. Role of USG in menstrual disorder. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you. Thank you. Hello, everyone. Good afternoon. So, I'll not waste much time and I'll just start with the role of ultrasound in menstrual disorders. So, basically, let's just get started with the types of menstrual disorders. So, there is oligomenorrhea, which is infrequent menstrual cycles, which are last more than 35 days apart. There's polymenorrhea, which is frequent cycles, less than 21 days apart. Dysmenorrhea is painful menstruation. Then there's menorrhagia, where there's heavy menstrual bleeding. There's hypomenorrhea, where there's only a scanty menses or just probably spotting. And then there's menometrorrhagia, where there's heavy bleeding in between the cycles. Okay, so first we'll just look at oligomenorrhea and polymenorrhea. Okay, the most common cause of oligomenorrhea and polymenorrhea is anovulation, where the most common one is PCOD. Okay, so on ultrasound in PCOD is one of the things that we can see on ultrasound very well. It's a heterogeneous disorder basically. It is characterized by excess androgen production and it interferes with the reproductive, endocrine, and metabolic functions. The recent guidelines for USG criteria is the patients who are more than 8 years post menarche. There in USG, what do we see is follicle number per ovary. Okay, if it's more than 20 in at least one ovary, or follicle number per section is more than 10 in at least one ovary, or the volume of the entire ovary is more than 10 ml, such that there shouldn't be any corpus luteum cyst or any dominant follicle, then we give that as a PCOD on USG. The other morphological features on USG for PCOD are hyperechoic central stroma, that is peripheral location of the follicles. The first slide is showing that it is string of pearl appearance. This is what is hyperechoic stroma, that is increase in stroma size, and as you can see the ovarian volume is also more. Also there is increased vascularity in the stroma. So these are subtle signs of PCOD which are seen. So follicle number per ovary, which is more than 20, it is the most accurate marker for PCOD on USG. Also in girls who are less than in adolescent. So adolescent PCOD, we do not use USG as a criteria for diagnosis. That is a very important takeaway point. Okay. So next we come to dysmenorrhea. Dysmenorrhea is commonly known as painful periods. Primary dysmenorrhea is very physiological. It is just prostaglandin concentration being high, and when you shed the lining, that's the time the pain is there. Once the period flow starts, the pain decreases, which is physiological. Then there is secondary dysmenorrhea, where there is the most common cause is endometriosis. There may be submucosal fibroid and subserosal fibroid, which would specifically cause dysmenorrhea. Adenomyosis also causes dysmenorrhea in many patients. And then there is pelvic inflammatory disease, PID. So let's look at each one of them. So first we have endometriosis. What is endometriosis? Is nothing but the endometrial epithelium and glands which are at any ectopic site outside the uterine cavity. So TVS has been shown to have more sensitivity in 90% of the patients in detecting deep endometriosis if you assess the anterior as well as posterior compartment. Okay, so TVS also has the ability in real time to assess dynamically the mobility and site specific tenderness. This is known as superficial markers, okay, which are suggestive of superficial disease as well as pelvic adhesions. The most common one being if there is a loss of sliding sign on transvaginal ultrasound, it indicates that there is obliteration in the pouch of Douglas. Such things help us in planning surgery. So TVS is the first line of imaging for endometriosis, okay, where uterus is usually seen as a anteverted retroflexed uterus, known as a question mark sign. Also, serosal nodules can be seen. Usually, the endometriotic nodules they are solid and hypoechoic. The typical ovarian endometrioma has a ground glass appearance. That is because of the collected blood clots, okay, and it typically has no flow on color Doppler. Whereas in a differential diagnosis, if there is a hemorrhagic cyst, then it will have blood flow, whereas ground glass appearance of the endometrioma doesn't have a blood flow. Also, if there are adhesions in the POD and posterior compartment, then both the ovaries are stuck behind the uterus, known as kissing ovaries. Okay. Then fallopian tube may show as a hydrosalpinx on severe cases in deep endometriosis. Also, there's a uterosacral ligament thickening or a hypoechoic nodule over the USL or even over the posterior vaginal wall. There may be a thickening or hypoechoic nodules. In the next slide, I'll be showing you all of this in detail. So here, if you see the first USG, these are typical ovarian endometriomas. They are well circumscribed and they have this typical ground glass appearance. And if you see, there is no vascularity seen here inside. Okay. Now here, this is in the posterior compartment, the posterior cervical wall. This here is the hypoechoic nodule. It's irregular and hypoechoic. Okay. Same here in the posterior, this is the vaginal wall. Posterior vaginal wall, there's a solid nodule. It's infiltrating the cervix too and the muscularis propria. So the nodules of endometriosis, they are solid, they are hypoechoic, and they are irregular. And they will not take any blood flow. Now let's come to deep endometriosis. Deep endometriosis can affect multiple organs in the anterior and the posterior compartment of the pelvis. Bladder, in bladder, the most common sites are the base and the dome of the bladder. Usually it involves the muscularis layer, doesn't involve the submucosa. In rectosigmoid colon also mostly nodules are present. Okay, these nodules they present as an extraluminal growth, meaning it grows out from the serosa to the innermost layer, from serosa to the innermost layer. In POD, typically the sliding sign is negative, meaning that there are adhesions in the POD. Okay. Same is with the utrovesical region. If there is obliteration or there are adhesions, it means the sliding sign can be assessed there and the sliding sign would be negative. Okay. In the next slide, couple of slides, I'll be showing you in deep endometriosis. Here, if you see again, it's a hypoechoic nodule, rectovaginal nodule. This is the rectum. This is the posterior vaginal wall. Okay, and it's a rectovaginal nodule here. This is the bladder. This is the uterus. This is the bladder base. Here is the again bladder endometriosis. If you can see, it has been infiltrated. This is bowel endometriosis. It is intestinal area. Okay. So it is affecting the muscularis propria. It's again a hypoechoic nodule right in the center. And here also, if you see, but the submucosa level is intact. The muscularis has been affected. So there are a couple of signs in deep endometriosis related to the bowel, especially for a hypoechoic nodule. So one is it's a regular hypoechoic nodule where there are no spikes. Here if you see, then in the hypoechoic nodule, there are these spikes which are going towards the bowel. So it is known as moose antler sign. Okay. Here along the nodule tails off in the end or it is narrowed down. So here it's known as the comet sign. This is how it would appear on a diagram. Here, this is known as pulling sleeve sign. The nodule is extending and there is retraction also. So it's known as a pulling sleeve sign here, right here. Okay, so these are the things which are seen on transvaginal ultrasound for endometriosis. So basically, for endometriosis in a transvaginal ultrasound, there are four steps. First is you evaluate the uterus, you evaluate the ovary. Okay, then you evaluate the anterior compartment and the posterior compartment, where first you look for superficial endometriosis in the form of pelvic adhesions, which can be checked by a sliding sign. Okay, and then for deep endometriosis, you look for the anterior as well as the posterior compartment. Okay, also, one more important thing, suppose if there is deep endometriosis, always extend your sonography, do USG abdomen, and just check for kidney and ureters. Okay, just rule out hydronephrosis. TVS, deep endometriosis, does help. TVS helps in planning for the surgery too. Now let's come to the next most common menstrual disorder, which is menorrhagia. So, menorrhagia is defined as heavy menstrual bleeding more than 80 ml or a prolonged menstrual bleeding which is more than 7 days. The most common causes of menorrhagia are uterine fibroids, adenomyosis, polyps, endometrial hyperplasia, endometrial cancer, sometimes ovulatory dysfunction, and then the systemic causes are bleeding disorders, and then so on and so forth. Okay, so we will look only into the causes which can be diagnosed on ultrasound. So let's first start with fibroids. So fibroids is nothing but benign tumor, smooth muscle of the myometrium in the uterus. So the FIGO classification everybody would be knowing. Okay, so we have submucosal, intramural, and subserosal. So as and when I show you every type on USG, I'll tell you this classification. Okay, but just remember 0, 1, 2 is submucosal, 3, 4, 5 is intramural, and 6, 7 is subserosal. The eighth one is other fibroids, meaning cervical fibroids or extrauterine. Okay, so like I said, first mode of imaging for fibroids is also sonography. TVS is better than TAS, sensitivity wise and specificity wise. The most common characteristic appearances are solid, concentric, it's a hypoechoic mass, very well defined, and does have a little amount of acoustic shadowing. Atypical types will show calcification as a echogenic foci. The necrosis in the fibroid may show as an isoechoic lesion. And also sometimes there are cystic spaces for cystic areas of degeneration in the fibroid. So this here, it's a intramural fibroid. It's FIGO stage 3, meaning the fibroid is just touching the endometrium, if you can see. Whereas here, this here fibroid is a intramural fibroid FIGO 4 where it is 100% intramural, not touching the endometrium. Okay. This is subserosal fibroid. It's FIGO 5, which means that it is less than 50% subserosal. And here, this is a proper subserosal fibroid, meaning FIGO 6, where it is less than 50% intramural. If you can appreciate, these are all round structures, hypoechoic masses, pretty much circumscribed. If you can see the white specks here, so these is the fibroid with calcification here. Here, this one is a cervical fibroid, which is FIGO 8. Any fibroid outside the uterine cavity, outside the uterus meaning. Now this here is a pedunculated fibroid outside. Okay, it's FIGO 7, serosal fibroid pedunculated. This is most commonly confused with any other adnexal mass. So the most important way to differentiate it from adnexal mass is that this fibroid will always have blood flow on color Doppler. There will be circular blood flow on the color Doppler, whereas any adnexal mass would not have it. Like pretty ovarian tumors, like a Brenner's tumor, which has more of fibrotic tissue in it, they will not have flow on Doppler. This is sonosalpingography. Okay, so sonosalpingography is done by installation of normal saline via a Foley's catheter number 6 into the uterine cavity to delineate either submucosal fibroids or polyps. So here we have FIGO 0 and FIGO 1. FIGO 0 is completely pedunculated intracavitary fibroid, if you can appreciate here. Whereas this is submucosal FIGO 1, where more than 50% is submucosal. Okay, so the most important this takeaway point is that in sonosalpingography you are able to delineate the margins of the fibroid, which is also helpful before doing a surgery to decide the mode of surgery, whether you can do it only hysteroscopically the surgery, or a laparoscopy would also be required depending on the extent of the submucosal fibroid. Also, sonosalpingography helps in differentiating a polyp from a pedunculated or submucosal fibroid. Yeah, so like I said, in submucosal fibroid, it is usually hypoechoic and it has multiple or circular feeding vessels, whereas for an endometrial polyp, the pathognomic sign is a single feeding vessel. Okay, it's a single feeding vessel here. Okay, so it is homogeneous and it's hyperechoic with a single feeding vessel. Whereas submucosal fibroid, okay, it has circular feeding vessels and it is hypoechoic. Okay. So in differential diagnosis, one is pedunculated fibroid with adnexal mass and one is submucosal fibroid with endometrial polyp. So now we are moving on to adenomyosis, another common cause of menorrhagia and dysmenorrhea. Again, it's a benign disease of the uterus. It is characterized by ectopic endometrial glands and stroma into the myometrium. The four types which are distinguished on sonography are diffuse adenomyosis, which is the most common one. Then there's focal adenomyosis, then there's adenomyoma. Many people take focal adenomyosis and adenomyoma as a single entity. And then there's cystic adenomyosis. So sonographic features of adenomyosis are actually operator dependent and technique dependent. Also, even in adenomyosis, TVS is more sensitive and specific compared to TAS. So for adenomyosis, now recently there is this morphological uterus sonographic assessment, MUSA. It's a diagnostic criteria where presence of two or more of this 8 highly diagnostic criteria of adenomyosis. If two are there, then we call it as adenomyosis. So what are these 8 criteria? If you can see here, there is asymmetric myometrial thickening where the posterior wall has more bulkiness. So if there's any globular thickening or asymmetrical myometrial thickening, that is one of the signs. Okay. Then there are myometrial cysts. Okay. There are hyperechoic islands. Then there's this fan-shaped shadowing due to the irregular endomyometrial junction and linear striae. There's increased vascularity in the myometrium. Okay. Also, there are these linear nodules, echogenic, hyperechogenic nodules, which are seen. Also, the thickening of the transitional zone. So, these are the 8 criteria, of which if 2 or more are present, then we are considering it to be diagnosis for adenomyosis. Okay. Now let's just look at all of them in detail. So here you can appreciate this is asymmetric uterine enlargement, okay, in the posterior wall. Okay, so it's more bulky, globular. Okay, here there are these hyperechoic areas and this is hypoechoic. So it's a heterogeneous echo texture of the myometrium. Okay, here, like I said, there is indistinct endometrial and myometrial interface. It's indistinct, it's irregular. Also, the vascularity is increased. And this is a typical small anechoic cyst, if you can see. These are all the anechoic cysts in the myometrium, okay, which are also one of the specific signs for adenomyosis. And this is also another specific sign for adenomyosis where there are linear striations coming from the endometrium. Okay, these are hyperechogenic linear striations, looks like fan shaped. Okay, and here this is just a 4D USG showing adenomyosis. 4D is not required for diagnosis of adenomyosis. I just took a picture. And here this is a sonosalpingogram again showing a myometrial cyst, and this is a adenomyosis, focal adenomyoma to be precise, okay, in the cavity of the uterus. Okay. Even sonosalpingogram is not necessary for diagnosis of adenomyosis. So for differential diagnosis, of course, focal adenomyoma is most commonly confused with intramural fibroid. But like you can see, this is the fibroid. Fibroid is usually regular, circumscribed, whereas adenomyoma, even though it's a focal thing, still it is heterogeneous, irregular. Okay, that's the main difference between the two. Still, it can be confused. And sometimes they both are associated, meaning there is fibroid also and there is adenomyoma also in the same uterus in the same patient. Many times it happens. So now next, again, we go to endometrial hyperplasia and carcinoma, which is one of the most common causes for menorrhagia in perimenopausal, also in postmenopausal bleeding. That is, in that also TVS is the first line of management for diagnosing. So endometrial hyperplasia is nothing but the abnormal proliferation of the endometrial glands and the stroma. In postmenopausal women, if the thickness is more than 5 mm, then it is considered to be abnormal and requires evaluation. TVS is the first diagnostic procedure for such patients. The USG features for hyperplasia include its homogeneous but sometimes can be asymmetric focal thickening, which may mimic a polyp. Okay, and sometimes cystic changes are also seen. However, if it's endometrial cancer, then we do see irregular endometrial thickening. Sometimes a polypoidal mass lesion can be seen. Many times in postmenopausal women, there may be intrauterine fluid collection in endometrial carcinoma, and of course, sometimes there's frank myometrial invasion. However, USG cannot really differentiate between hyperplasia and carcinoma. Diagnostic hysteroscopy is the answer for that. Okay, apart from MRI, of course. So here I'll be showing you endometrial carcinoma. If you see, this is cystic spaces and a thickened, very thickened endometrium. Here are the cystic changes in the endometrium. Okay. Eventually, a hysteroscopic guided biopsy would confirm the diagnosis in such cases. This is also a very thick heterogeneous endometrium. Also, a thick hyperplastic endometrium will have an increased vascularity if you see here. Here also it's a thickened endometrium. Okay. Now let's go to the next one, which is hypomenorrhea. It is usually very light menstrual flow, sometimes only spotting. The only thing which we can look for in USG in hypomenorrhea is for Asherman's syndrome. Most of the other causes are medical causes. So Asherman's is nothing but uterine synechia, or in simpler words, okay, so ideally, hysterosalpingography along with SIS is done as a first line for adhesions to just check for adhesions, though hysteroscopy is diagnostic in such cases. So adhesions would appear as a bridging bands of tissues which distorts the cavity. There would be always a thin endometrium even in the secretory part of the cycle. Okay, flimsy adhesions can be seen as thin membranes in real-time scanning. On HSG, typically adhesions are seen as filling defects, which is diagnostic. So if you could see here, this is Asherman's syndrome. There are this typical echogenic foci in a thin endometrium. This SIS has been done. Okay, so these are the intrauterine adhesions, if you can see. This is transverse and longitudinal section of Asherman's syndrome. This is the uterus, very, very thin endometrium. Nothing can be appreciated much. Okay, so those are subtle, and the clinical symptoms are most important in Asherman's, followed by HSG, followed by hysteroscopy. Now we come to metrorrhagia and menometrorrhagia. See, metrorrhagia is bleeding which occurs anytime in between two menstrual cycles. The most common cause would be an endometrial polyp, usually. Okay. Of course, CA, cervix, CA, endometrium are the lesser common causes. In menometrorrhagia, it's also irregular interval bleeding, but the amount and duration would vary. And the causes would be similar, which causes menstrual spotting like endometrial polyps. So now let's jump to polyp. Endometrial polyps are nothing but they are just nodular protrusions of the endometrial tissue. It has very typical ultrasound features. Okay, there's a hyperechogenic, solitary single mass inside the cavity. Okay, and it is homogeneous. Also, it interrupts the triple line, so there is discontinuation or interruption of the entire triple line of the endometrium. Also, there is a slightly hyperechoic line surrounding the polyp, all around between the polyp and the surrounding endometrium, which is known as the bright edge sign. And something which is pathognomic is a single feeding vessel. The best time to look out for an endometrial polyp is post-menstrual from day 5 to day 9. So these are the sonography findings or signs for a polyp. If you can appreciate, this is a solitary single mass. It is hyperechoic, okay, and it's homogeneous. Here, if you see, this is a nice triple line here, but it gets interrupted with this polyp here. Okay, so it's interrupted mucosal sign. Single feeding vessel is here, and this is what I was talking about, the bright edge sign. You can appreciate the bright edge here around the polyp and between the endometrium and the polyp. Okay, the most important thing is a single feeding vessel. Of course, 3D ultrasound also helps in delineating the border of the polyp. It also helps to plan surgery, in fact, whether surgery is indicated or not, especially in infertility patients, because that is the site of implantation of the embryo. Sonohysterography, like I said, it is useful to differentiate from a submucosal fibroid. Okay, sonohysterography is also usually done during the proliferative phase. Okay, it is as accurate as hysteroscopy in diagnosing a polyp. However, it is not routinely mandatory to do sonohysterography for every patient to just diagnose it. In postmenopausal bleeding, many times the endometrial thickening is diagnosed, but many times it's a polyp. So, in such cases, sonohysterography is of use to differentiate whether it's a endometrial polyp or it is just endometrial hyperplasia. So, differential diagnosis of polyp are again many. One is the submucosal or pedunculated intracavitary fibroid, which I said. There's this typical foci of endometrial hyperplasia actually, which looks like a polyp. Then endometrial carcinoma, again, if you see the endometrium is ragged and jagged. Okay. There's this intrauterine blood clot, which is also very commonly associated and a good differential diagnosis for polyp, and retained products of conception, but then they would not have the single bleeding vessel. So that is one of the most important thing to look out for in a polyp. So, like I said, let's summarize. So basically, USG is actually a first mode of imaging to investigate any women who comes with a menstrual disorder. It's just a table which is showing, suppose if a patient comes with oligomenorrhea, from the USG point of view, we would think PCOD and this functional cyst, a simple cyst, okay? They are just a hormonal imbalance which are seen as simple cyst in the ovary where patients either have oligomenorrhea or they have menometrorrhagia, okay? Whereas if it's menorrhagia, there's fibroid, adenomyosis, endometrial hyperplasia, endometrial carcinoma, also IUD, intrauterine device, intrauterine copper T is one of the most common causes of menorrhagia, which can be diagnosed. And on USG, sometimes it's a misplaced copper T. So USG is also one of the important diagnosis for a misplaced copper T. Also, sometimes if it is embedded, then we do USG guided hysteroscopic removal of the copper T. So USG is plays a role in intrauterine device removal if it's embedded. This menorrhea again, endometriosis, adenomyosis, fibroid, PID also, like I said, hydrosalpinx can be seen on a transvaginal ultrasound. Okay, and menorrhagia, menometrorrhagia would have endometrial polyp and endometrial hyperplasia, and hypomenorrhea would have Asherman's. These are only the USG based causes which I have just summarized. So whenever a patient comes to you with menstrual disorders and you're about to do a TVS, this is the thing which you keep in your mind. Okay, thank you. If you have any questions, please let me know.
Thank you so much, ma'am, for your wonderful presentation. We do have some questions if you like to take that up.
Yeah, sure.
So, ma'am, the first question is, what are the potential benefits of incorporating artificial intelligence into ultrasound diagnosis for menstrual disorder?
Yeah. So see, the potential benefits are, like I said, in adenomyosis, it becomes operator dependent. In fibroids, many times it becomes operator dependent. So then it becomes more streamlined, and the chances of error or chances of having a main protocol is there. So that is the main advantage of having AI in USG for menstrual disorders.
The next question is, ma'am, what are the emerging ultrasound technologies or advancement that could impact the diagnosis and management of menstrual disorder?
Yeah. So the newer ones basically, there's real-time ultrasound, especially for deep endometriosis, which can be used. Also, then there is sonohysterography, which is not newer one, but it helps in differentiating polyps and fibroids.
Ma'am, there is one last question. How does USG compare with other imaging modalities like MRI or CT in evaluating menstrual disorder?
Yeah. So see, obviously MRI and CT in cases like endometrial carcinoma, they are better. Okay. In Asherman syndrome, hysteroscopy and hysterography are better. The first line, always the first line for imaging is TVS. However, in endometrial carcinoma, endometrial hyperplasia, then MRI and CT has a role to play.
Ma'am, that's all from our audience, and thank you so much for answering all our questions.
Thank
Before
you.
concluding, ma'am, any take home message from your end?
Take home message is that always do a transvaginal ultrasound of any patient who comes for menstrual disorders. Also, take home message which I just missed out on my slides is this: always rule out pregnancy in TVS, transvaginal ultrasound. Always rule out pregnancy.
Thank you so much, ma'am, for joining us today. With your permission, I would like to conclude today's session. Thank
Thank
you.
you. Thank you.
Thank you, ma'am.